The second speaker, Professor Dr. Mervat Mattar. She will talk about frontline therapy and CLL. Please, Dr. Mervat.
Thank you, Dr. Adel, for introducing me, and I thank Dr. Amal Zidan for being the chairperson. And I think we need to start the Janssen Symposium right now. We are missing Dr. Mahmoud Salah for the second part of the symposium. So let me just introduce you to the management of treatment-naive chronic lymphocytic leukemia patients. And I thank Dr. Hala for making my job easier, because she introduced us to the diagnosis and prognostic markers of CLL that might be of value in the treatment of treatment-naive CLL first line. And of course, I have to tell you that the key factors determining clinical course in CLL are diagnosis, whether late or early, the biology of disease itself, as Dr. Hala has mentioned, whether it is aggressive or resistant or not, the responsiveness to treatment, as Dr. Mohammed Azazi, my dear colleague, just mentioned before, the age and health state of the patient, because you might have a patient that needs treatment, but you cannot give him the right treatment because he cannot tolerate. And the variables that predict CLL disease course are not entirely independent. You have the aggressive disease biology, which probably will have a more advanced disease and probably more resistant to treatment, or you can have upfront the non-aggressive biology, which can be diagnosed early, elderly age, and better response to treatment if needed. And as you can see, as of 2016, the International Prognostic Index not only does it include the BNA or the Ray stage, but it also includes the age and the beta-2 microglobulin level, whether high or low, and the immunoglobulin heavy chain mutation status, as mentioned by Dr. Hala, and deletion P17 and a TP53, deletion 17P or TP53 mutation, as also mentioned by Dr. Hala, and they are giving them grades, scores. And now the prognostic index is either low, intermediate, high, or very high. That was back in 2016. However, things are changing, and I will show you why they are changing. Why did they put this prognostic index in 2016? Because they included some poor prognostic markers, especially those in red. The ones in blue are because those in red are there. And what are these? These are the 17P deletion, the 11Q deletion, and the heavy chain mutation. Because one of them or all of them are there, then these are poor prognostic markers at that time in 2016. Let us see if things are changing. How about deletion 17P? We all know that deletion 17P is a key cytogenetic abnormality, and it results in the loss of TP53 gene. This TP53 gene is a guardian of the genome. It guards the genome against malignancy. Now, once there is a mutation in this gene, then malignancy comes. Yes, but I'm talking about treatment-naive CLL, first line. Can I find TP53 mutation? The answer is yes. 3 to 10% of newly diagnosed patients can have this problem up front. Now, the problem is 17P deletion equals less responsive CLL at that time, 2016. A problem also is that these patients with 17P deletion, if they need treatment, they will be resistant to chemotherapy. They'll be resistant even to rituximab. And so, as of 2016, they are looking for other types of treatment that can help and that can overcome this poor prognostic problem. Of course, loss of TP53 equals no apoptosis, and so that means more CLL disease. Another problem is that 17P deletion might not be there. The patient might not be harboring 17P deletion, but the mutation can still be there. So looking only by FISH might not catch the mutation. So you have to look for both. And as has been mentioned before by Dr. Hala Farawila, mostly 63%, you can have both the deletion and the mutation. But there are others when you can have either. So you have to detect both. If you do not find the one, you can find the other, especially the mutation, not just absence of TP53 gene, but the mutation of TP53 gene. And this is even worse. As you can see here, 17p deletion, down goes the progression survival, down goes the overall survival. And even with treatment, as you can see here, the ones in blue are 17p deletion, the ones in red are non-17p deletion. And even if you add not just FC, but FCR, this will not help the patient. So if you have a 17p deletion or a TP53 gene mutation or deletion, this is not the right type of treatment for these patients. And so it has been recommended as of 2018, you have to do a 17p deletion and a TP53 mutation to each and every patient CLL up front, so as not to miss. Does this mean that you go ahead and treat? No. You just know that this is there. So once you need to treat, you're going to use some other weapons, not just the chemoimmunotherapy that you are used to. Maybe another form of immunotherapy or other form of targeted therapy. Do I need to repeat this test if the patient relapses? The answer is also yes. You need to repeat it on relapse. How about the heavy chain immunoglobulin mutation? This is new in Egypt. However, this has been known for years and years all over. If you have a heavy chain variable region mutation status, this equals an immature form of CLL, not a mature form. And with immature forms of CLL, response to treatment is very bad. Let me show you. As you can see here, FCR, FC, or even BR. So even if you need to treat with Fludara, cytosine, if you need to add rituximab, or you are going to use bendamustine rituximab, as long as this mutation is there, response is very bad. So do not start with these types of treatment because you're not going to help your patient at all. Now, is it found up front? The answer is yes. Almost 50% of patients have unmutated form. So I think we need our lab colleagues, we need to think and really think of making this mutation lab detection available for us clinicians so that we can ask for this test up front and know that if and when the patient needs treatment, then I'm going to treat him differently, not just the regular type of treatment. Please, labs, we need accredited, calibrated labs for this test. This is very important. It is as important as 17p deletion. It has been mentioned that international guidelines recognize the growing importance of detecting this mutational status. How about deletion 11q? Dr. Hala just mentioned that with deletion 11q, you have a more resistant treatment. It has also been associated with Richter's transformation and increasing in the size of the lymph nodes. But still you can find it up front. And there's another problem. If you find a heavy chain mutation, you can find also an associated 11q mutation. And this is even worse. In fact, you can find the three together. And this is even worse and worse and worse. And as you can see here, if you have the 17p deletion is the green. This is the worst. But the next worst is the 11q mutation in yellow. So both green and both yellow curves are very, very bad prognosis, very, very bad survival. And this is going to define our treatment decisions and the cards that we need to play with in chronic lymphocytic leukemia. Now, there is always a balance between life and death in a CLL cell. Let me just show you. If the yellow part wins, then there is more CLL survival. But if the blue wins, then this is less survival, more apoptosis. And one of the factors that can help survival is the Bruton kinase. So you have a Bruton kinase inhibitor, then you tip the balance and you kill more CLL patients, and you help more CLL patients to go into apoptosis. So Bruton kinase, as you can see, which is shining, is a critical kinase for B-cell malignancy growth and survival. And that is why they devised IMBRUVICA, which is a Bruton kinase inhibitor. Let us see if this is one of the keys to help patients that have poor prognostic criteria. Well, they looked at RESONATE-2 study. It's a long-term efficacy and safety of first-line IMBRUVICA treatment for patients with CLL, small lymphocytic leukemia. They followed them up to 5 years until now. Let us look at these. It's a phase 3 trial, and they included patients either with oral IMBRUVICA, oral ibrutinib, versus oral chlorambucil. الغلبان chlorambucil كل الناس بتقارن نفسها بيه. And it's a 1-to-1 randomization. It's an oral therapy. The medication is 140 milligram tablets, and they are to take 3 tablets, 1 dose, orally once daily. And they followed the patients up. Let us look at primary and secondary endpoints. Primary endpoint was progression-free survival, because we all know that CLL patients live very long, so they do not look for overall survival as primary endpoint. But primary endpoint is usually progression-free survival. Secondary endpoint, you get overall survival, overall response rate, rate of hematologic improvement, and of course safety, because this is a new drug. Eligibility were patients that were treatment naive, more than 65 years of age, elderly, ECOG performance status less than or equal to 2, a good neutrophilic count, they were not neutropenic, platelet count more than 50,000, they were not very much thrombocytopenic, and of course good liver and kidney functions, and no chromosome 17p deletion. That was up front, but I'm going to show you some other results later on. And as you can see in red, there were many patients with chromosome with 11q deletion, and many patients with the unmutated phase. Now, patients were included. The number was 136, so this was a good number. And as you can see, of 136 patients, treatment with first line was ongoing in 79 patients, and 56 patients discontinued treatment within 5 years. Now, this is the progression-free survival of all patients, and the one in blue down there is the chlorambucil الغلبان, but the one in yellow is the progression-free survival of IMBRUVICA, which was much, much better in all cases, with an 85% reduction in the risk of progressive disease or death, which is really amazing. Let us look at the subgroup analysis. In all subgroups, patients receiving ibrutinib or IMBRUVICA fared better, especially so those with chromosome 11q deletion or those with the unmutated heavy chain gene. And so all patients fared well, especially those with poor risk presentation. That was back in 2015. Let us look at 2019. This is published in Leukemias in October 2019, so especially this month. And up to 5 years now, the response is still the same. We have all subgroup better response with IMBRUVICA versus chlorambucil, and not only the unmutated heavy chain gene, and not only the 11q, but there were some cases that were reported to be TP53 positive. That was not looked up front, but now we know TP53 gene positive mutation, and still they fared better. And so all the prognostic problems that were faced with FC, FCR, BR, they were completely eliminated, or much, much more eliminated, with the use of ibrutinib first line. And as you can see here, whether mutated or unmutated, right or left, patients receiving ibrutinib fared much better. So it did not really matter if the patient was mutated or unmutated up front. How about the overall response with IMBRUVICA? Now the green is the very high CR, and the red is the PR, the blue is the PR, and as you can see, as you go along, as the patient continues the treatment, the response gets better. So it is not only some form of response up front that stays that way, no. As long as the patient is receiving the treatment, the response is getting better and better all the time, up to week 60. Does this mean that ibrutinib has to be continued? The answer is yes. Patient should continue ibrutinib as long as the patient is responding. You should not stop for the time being. Same dose for the time being, yes, same dose for the time being. And this is up to 5 years. I'm now giving a patient the same medication for 5 years. Let us look at safety. First, hematologic findings. In blue is the hemoglobin. And the hemoglobin, up front, sometimes you get some anemia. But as you can see, as you go along, hemoglobin rises and continues to rise. How about platelet number? Platelets here are in red. Maybe up front you can get some thrombocytopenia. But as you go along, platelet count increases and continues in an acceptable level. And so hematologic toxicity, as you go along, does not increase at all. In fact, it goes away. How about other safety problems? Other side effects? Some diarrhea, some nausea, some arthralgia, maybe some vomiting. But let us look at things that we need to take care of. Hypertension. These are patients that are more than 65 years of age. Please control your patients, your hypertensive patients, and monitor them as you are giving ibrutinib. Okay, how about atrial fibrillation? There is a very small tendency of some cases reported to go into atrial fibrillation with IMBRUVICA. And these are elderly patients. So please follow up your patients with ECG and with cardiology consultation every now and then. And if the patient is already AF, atrial fibrillation, well, you need to think again if you're going to give ibrutinib. Maybe some other line of treatment would be better. How about dose reduction? Did patients need to decrease the dose because of side effects? And the answer is, as you go along, in pink, as you go along, you do not need to decrease the dose. Maybe up front, but as you go along, the dose reduction schedule is not there. And so, ESMO guidelines, frontline therapy, ibrutinib, IMBRUVICA was put as one type of first-line treatment. Oral therapy. And even if you have a heavy gene chain mutation or heavy chain gene mutation or an 11q mutation, still ibrutinib was put as one type of first-line therapy. Both in patients that are young and fit and patients that were unfit. Because it is an oral therapy, it is well tolerated. And conclusions of RESONATE-2, which is the longest phase 3 trial using ibrutinib first line, it showed that after a median follow-up of 5 years for patients in the RESONATE-2 study, first line single agent IMBRUVICA continues to demonstrate a significant and durable clinical benefit in older patients. And it helped these patients, including those with high-risk prognostic features, such as the TP53 mutation, the 11q mutation, or the unmutated gene. No new safety signals were seen. For five years, no new safety signals were seen, and many adverse events decreased over time. And so this proved that long-term use of ibrutinib was efficacious and it was safe. And with that, I thank you.
Thank you, Dr. Mervat, the eminent professor of clinical hematology, for this very informative and very interesting presentation.